So I'm joined by some colleagues from the Bromley by Bow Centre, and we're going to be discussing how social prescribing came to Bromley by Bow quite a few years ago now. My colleagues would also talk to you about what is happening at the moment and kind of the future vision, as I mentioned before. We'll have some time for Q&A, so please do ask any questions you have at any point. I'm keeping an eye on that, so we can ask that during the Q&A time. And then we'll have a little discussion, panel discussion, just talking about, again, how can we make all the factors kind of align to have social prescribing services that are going to help and support our local communities. So yeah, that's kind of it for me. Dan Hopewell is going to talk to you a little bit about the importance of social prescribing now and how it came to Bromley by Bow initially. He's the Director of Knowledge, Knowledge and Innovation at the Bromley by Bow Centre, and he's going to talk to you now. Dan, I think you're on mute now.
Great, thank you, Berenice. And yeah, it's a great pleasure to welcome everybody to this webinar from Bromley by Bow. And I guess in different times we'd probably all be sitting at Bromley by Bow, which would be so exciting to be able to show you the physical setup of Bromley by Bow. So just to really start us on this webinar and to think about social prescribing, where it's come from and where it's going to. Bromley by Bow, for those of you who don't know us, is a community centre, a healthy living centre in East London. It has been developed over the last 37 years. So that takes us back to the mid-1980s, actually a time of really quite significant social convulsion in the UK, and certainly in terms of East London and our community there, kind of great deal of abandonment of a community. The docks had closed down in the 50s and 60s. There was considerable unemployment and poverty. And into this arrived a priest in 1984 to encounter a very extensive set of church buildings and a tiny congregation, and the whole place really opened up for a couple of hours on a Sunday. Andrew, the priest, invited the community in to come and build a community hub at Bromley by Bow, and started to sort of tap into the resources and interests of that community that consisted of a number of different distinct parts, really. The sort of traditional white working class community of East London, overlaid by significant migration from Bangladesh in the mid-1970s, a decade earlier, and then lots of empty housing, which had been taken over by housing cooperatives and artist co-ops and so on. And this was kind of the confluence of Bromley by Bow. It was some way into our journey of building this community hub with a small cafe, artist studios, food growing, and a social care program run by our artists and local people, that we kind of stumbled into the world of primary care, really prompted by the poor quality of primary care for our community at that time. And we developed what we think is the first health centre built by the local community and rented back to the doctors, first health centre, if you like, built by the patients. And this became the first healthy living centre in the UK. This is 22 years ago now. And that was when we started to develop social prescribing, the idea that GPs, nurses, healthcare assistants would be referring patients over to non-clinical provision provided in the community side of the hub. And that was really the beginning of our journey into social prescribing. We didn't have any link workers at the time. Nobody had come up with that term, social prescribing link workers. And we were amongst the sort of vanguard, joined by others across the country in Devon and Newcastle and Rotherham and other places, who also, in a similar way, were joining up communities, voluntary sector organisations and general practice, and this idea of how they might work together. And then we all started to develop the concept of the social prescribing link worker role. And that's really been developing gently over a couple of decades, if you like. And then, of course, the NHS about 5 years ago have adopted social prescribing and the formation of primary care networks came as well, and the idea that they would all have social prescribing link workers. I think today, and I think today's discussion is going to be really fascinating. We're at a number of, if you like, staging posts or crossroads in the development of social prescribing. How does social prescribing develop going forwards? And it's sat at the moment in many places very much within primary care. Potentially, how do we kind of build it back out into the community again. How does social prescribing work with other initiatives such as community navigators, community development projects, and so on? I think we're in a very, very interesting space. We'll also be talking about today the development of specialist roles within social prescribing, mental health link workers, young people's link workers, welfare benefits link workers, and kind of the relationship with primary care, the relationship with communities, part of what we're going to be talking about today. And this, I think, is going to be fascinating to discuss that with you, and how we feel social prescribing will shape up in the next few years. And also, of course, that is very, very influenced by the learning that we've all done under the COVID context, which of course endures, and we're in another stage of that process now as well. So really looking forward to today's seminar, and really looking forward to hearing from what you as attendees are going to contribute to that through the interactive methods that we've got for you to express your questions and ideas as well. I'm going to hand back over to you now, Berenice.
Great, thank you very much, Dan, and thank you for this intro. That was really helpful. So now I will hand over to Emma Owen-Madison and Leila Sheree. So Emma is the Assistant Director for Population Health at the Bromley by Bow Health Partnership, and Leila is our Social Prescribing Service Manager. She works at the Bromley by Bow Centre as well. So not sure which one of you is actually starting, but I can see you, Emma, here. So I'll hand over to you now.
Thank you. So yeah, the plan is that we'll do a bit of a double act. So we'll see how it goes. So I'll just speak briefly really about the I guess the positioning of social prescribing at the moment. So, and then Leila will speak more about the detail and the kind of like operational and more about the specialist roles as well. So as Dan mentioned, social prescribing sits firmly within the context of kind of primary care in our context, but it's not limited to that at all. And I suppose over the last 2 years or so of COVID, we've really had an opportunity to think about how much we can, I guess, bolster the work of social prescribing within primary care, but also kind of further afield into the community as well. So I will share kind of our thinking around how we're doing that. And it's based around a sort of, can everyone see my screen? Can you just nod? Okay. Yeah, it's based around a sort of population health model of support, I suppose. So the first question we think about is what is population health? So rather than thinking about kind of individual conditions or individual circumstances, actually thinking about the experience of health and well-being within and between groups. So the reason we say it like this is because somebody could have diabetes, for example, and need a lot of support. So many of our patients with diabetes in the practices, for example, have a number of appointments every single year. And in fact, 39% of our diabetic patients in the last 3 months have been seen over 4 times. So lots of people that have kind of other factors that mean that they need more support. But then other people may have diabetes and be very able to self-care and manage quite independently. So it's really important to think about the experience of health and well-being, not just the condition, the presence or absence of a condition, but really think about what it's like for that person living in health or with a condition that needs some support. So, moving on. So then when thinking about population health, what we try and think about is principles, enablers, and then what drops out of that. So even though I'm speaking in our context, if you were to repeat this and do it in your own, then because there are many different people that kind of come together to make a population health system, it's so important that you in your area or we in our areas think about what are the principles that ring true for us. So for us, a lot of this is steeped in the wider determinants of health. So knowing that actually in our area, up to 90% of health outcomes are driven by non-medical factors. So that is a really critical point for us. Yeah, I'm glad that someone was off mute for that, because it is a really well.
Sorry.
It's okay. It is very much a wow factor that actually so much of our health is driven by things that actually have nothing to do with what happens within a GP practice or within a health setting. So really taking that seriously and thinking about how we address that as a fundamental part of the support that we offer. And then of course social justice as well. So we know that actually the main reason why we do any of this is because of the deep and entrenched health inequalities that exist within our community. So again, thinking about within everything that we do, how can we enable the gap of health inequalities to be bridged in some way. Then we think about enablers. So of course, it would be amazing if everyone just loved and accepted social prescribing, but we know that that's not always the case. So actually thinking about organizational change. So what are the conditions that are required within a practice or within an organization that allow this kind of work to thrive? Thinking about data. So how can you use the data? How can you create the data? Who owns the data? There's many, this could be a whole presentation in itself, but really thinking about the data and how you can use it to support your work as well. And then finally, governance as well. So who needs to be around the table? Who's accountable for what? Who makes the decisions? And how our community is a part of this as well. So finally, then after you've thought about all of that, then comes the kind of, okay, so what do you actually do? So then drops out of that a number of projects and work streams. I think the one that's most important for me at the moment, well, all of them are important, but really thinking about what kind of activities are community defined. So of course, organizations and institutions have their own priorities, but the community will also have a range of things that are important to them, and it's really important to tap into that. And then thinking about what is relevant and timely as well. So through COVID, we really realized that the needs of the community can change very drastically and very rapidly. So having a team that's able to respond to that really quickly is also really important. So then we get into what it actually looks like. So this looks quite like a busy slide, but it's the simplest way that I'm able to kind of I guess, summarize all of the work that we do across our population health team that works across the Bromley by Bow Health Partnership and the centre. So in the middle, you've got the kind of 4 key areas that we work across. So community leadership, individual and group support, teaching, training and learning, and organisational development. So these are the kind of 4 main strands that make up our population health programme. And of course, social prescribing, if I was to add another circle, would really sit firmly in the middle of all of this work. Then on the outskirts, we've got some kind of key work that we do. So the integrated health and wellbeing team. So that's really bringing together, it's a very fluid team. It's not something that is, you know, mandated to work together, but it's really bringing together all of those roles that Dan mentioned at the beginning. So care navigators, health and wellbeing coaches, social prescribers, those that are doing call and recall in the GP practices, social prescribers that don't call themselves social prescribers, all of these different things to kind of work together to see how we can support our sort of geography that we work within. And then the other thing to mention is around the data as well. So really, how do we come up with shared data agreements? How do we store the data? How do we share the data to ensure that everyone can have access to good quality data in a timely way? So next we go on to the team. So who is doing all of this work in Bromley by Bow, I hear you ask. So I'll also ask Layla to come in on this part as well. So this slide is really just an overview of all of the people that deliver across a number of these areas. So it's not one linear team. It's not kind of a team that are funded from one same place, even, for example, but because we all know that we're doing the same work in similar ways and that we have similar kind of goals and approaches to work, actually what we like to do is consider ourselves as one team, and then that means that we're able to share our resources, to share our knowledge, to share our insights, and also to support one another as well, which I think is something that's been really vital over the last 20 months. Before I hand over to Layla, I suppose the one thing that I did want to point out that we have got as part of the team is our patient directors. So as part of the governance of that we're developing at Bromley by Bow, it's really to have kind of more community voice as an embedded part of decision making. So we have a community advisory board, and as part of that we have patient directors who are also considered as part of this population health team. So with all of that being said, I'll hand over to Layla now to speak more about the team and then more specifically about kind of social prescribing and the delivery of it as well.
Thank you, Emma. That's great. Berenice, you can just keep that slide up. That's fine. Yeah, so as Emma said, that's how our sort of population health social prescribing team is looking. I suppose I'm going to speak to the Bromley by Bow Centre side of sort of the delivery of social prescribing for the next sort of few minutes. So we have been delivering social prescribing for a number of years at the centre, and we've been serving the kind of primary care network 6 area that sits in sort of Tower Hamlets, East London. So a lot of deprivation and poverty, huge sort of health inequalities. And I guess as social prescribers, our aim really is to be giving people time to explore what's important to them, as well as sort of supporting individuals to identify issues and challenges that they'd like to address. And in doing that, finding activities and services that will support them. So we, and Em, you can come in and sort of chime in, but I think it's around 50,000 patients in our primary care network. So a lot of patients that we're supporting. And the typical kind of referrals that we get in social prescribing, and I know for a lot of those of you that are on the call today that are delivering social prescribing as well, no surprise, our two main sort of concerns are around social welfare related needs. So that's things around sort of housing, benefits advice, financial management, homelessness, etc. And then sort of mental health needs. A lot of these are sort of low mood, anxiety and depression, but also sort of serious mental health issues as well. And then of course, we've got things like isolation and loneliness that have really sort of increased and accelerated because of the pandemic. And I think with all of these kind of reasons for referrals, you know, these things were always a barrier and a challenge for people, but things got a lot worse over the last sort of 2 years. Now looking sort of back at the team, I mean, the team seems like a huge number of people, but it didn't look like this before sort of March 2020. It was myself and 2 part-time sort of link workers that were essentially delivering social prescribing to 6 of the practices. And when the pandemic happened, obviously sort of NHS England sort of accelerated the recruitment of more social prescribing link workers. And this allowed us over a period of a few months to sort of recruit 3 sort of link workers through NHS England funding. In addition to that, we received some corporate funding to sort of recruit a more crisis social prescribing link worker that would deal with more of the urgent needs. And then later in November of 2020, we received some money from East London Foundation Trust to sort of deliver and develop a mental health community connector role in Tower Hamlets that would sort of be a part of that new care model of mental health transformation. So as a centre, we were traditionally delivering what we call sort of generalist social prescribing support. And that was kind of long-term support over 1 to 6 sessions, 1 hour each session. And we sort of developed different levels of support where the social prescribing link worker would identify what support was required. Some of that times it was 1 session, and a lot of that was around sort of identifying the issue and just signposting and making referrals. And then anything that was between 2 to 6 sessions took more of a sort of coaching, motivational interviewing kind of framework. And that was really around sort of behaviour change. And a lot of that, the social prescriber was the intervention, was providing that sort of emotional support, befriending if you like, but really working with people to kind of change their lifestyles. So when the pandemic happened and we managed to recruit more people into the team, we were able to kind of think creatively about what our kind of client pathway would look like. And so we developed different streams of support. We created the rapid response social prescribing service. And we have 2 rapid response social prescribing link workers that sit both within Emma's team and the general social prescribing team. So we're very much integrated. And their role is really to kind of deal with all of our urgent sort of needs. So people that need to be sort of signposted, seen very quickly, to things such as sort of food banks or homelessness issues, sort of more crises, and they have a quicker turnover of contacting people within 48 hours. We then have our generalist social prescribing service, and the rapid response workers work really closely with our link workers to kind of hand over any support that they've been providing to more of the generalist link workers, so that we can carry on that kind of longer term support in kind of building resilience and confidence. And then we have our direct referrals. So our referrers in primary care, they have the opportunity, when there's one clear identified need, to almost fast track that individual into that service. We're really lucky at the Bromley by Bow Centre as a voluntary sector organisation. We have social welfare teams that sit within the centre, as well as employment specialists. So we enable our referrers to identify if there's a clear need, such as, you know, it's very clear that this patient has a social welfare issue. We can kind of fast track that referral into the social welfare team so people can get seen quicker. We also have our mental health community connector pathway. So our mental health community connectors, this is a fairly new role that we've developed in the last year. And their role is really to deal with all of our sort of serious mental health issues. The mental health community connectors is quite an interesting role, because they sit not only within the voluntary sector in Bromley by Bow and primary care, but they also sit within the community mental health teams in secondary care. And that's really exciting, because they're a part of those blended teams. They're able to kind of promote and share, sort of speak to the sort of wider determinants in those clinical teams where those discussions might not necessarily be happening. Our mental health community connectors are very much embedded within the social prescribing structure, and so they really work well within the team. Over the last few months, we've also had time to kind of reflect further on this idea of kind of developing more sort of specialist roles within the team. And we've used some of that, some of the sort of NHS England recruitment of link workers to actually create a specialist role for a sort of social welfare link worker. This is really new for us. Rather than training a social prescribing link worker, we actually recruited a trained welfare advisor and trained them as a social prescribing link worker. And she sits within the social prescribing team as well. And this is, I think this is an amazing kind of role, because, as you know, most of our referrals that we get will have some sort of social welfare need attached to it. And having that insight and knowledge of somebody that can sit within the team that can provide that support has been extremely helpful. So our social welfare advisor deals with our direct referrals into social welfare, as well as providing support to the team when it comes to sort of understanding sort of social welfare issues, training, things that link workers can do within their sessions that are social welfare related, that doesn't require you to have a sort of information and advice and guidance qualification. And I think having that person in that role has put less of a strain on the team to feel like they have to carry these kind of complex issues that they might not necessarily have the sort of knowledge and resource for. So that's still very much new, and we're also working with the social welfare advice link worker is also working closely with our practices to start to support GPs and clinicians in how to kind of create some of those housing related letters that patients always request. I could chat more, but if anyone has any questions or would like to get in contact with me to find out a bit more about our service more informally, feel free. What I'll do is I'll leave my email in the chat for everyone. Is that all right, Emma? Have I covered everything?
Yeah, definitely. So sorry, I just stopped sharing for a second, but I'll share again. So I suppose the last thing that we wanted to mention was kind of some of the work that we're developing at the moment. So yeah, I'll hand back over to Layla. Some of it's been mentioned already, but these are some of the areas of work that we are going to be thinking about developing social prescribing into in the future. So work with young people, the specialist social prescribing that's already been mentioned, and then more around proactive social prescribing as well. So rather than waiting for a referral, actually using the information that we know to kind of reach out to people and offer the support and embed it as part of a routine part of our primary care offer as well.
Yeah, so thank you, Emma. So yeah, these are some of the sort of exciting things that we're trying to kind of develop over the next few months and into the sort of new year. As Emma's mentioned, I know sort of there's been a lot of spotlight on kind of expanding sort of who sort of social prescribing is being offered to. Children and young people is one of those areas that we're looking at. What we're doing at the moment is working to kind of actually develop a framework, because our service supports people over the age of 18. So we're working towards developing a framework that is suitable for people under the age of 18. What we are doing is we've sort of developed partnerships with our local secondary schools in the area to kind of pilot some of that work there. What we're doing is we're piloting sort of the family approach, and we're working with 10 families to provide social prescribing support to them in the school setting. And we're also going to be providing support to some of the sixth formers with their sort of mental health, and that's something that our mental health community connectors are going to be sort of focusing on. Emma mentioned some of the sort of proactive work of social prescribing. Traditionally, we receive most of our referrals from primary care. We also have a sort of self-referral method, but by far most of our referrals come from primary care, and we've been starting to think more about how we can kind of engage with people in the community and proactively engage them into social prescribing, rather than kind of relying on our sort of referrals coming in from primary care. In thinking of that, we've been thinking of where we actually place our social prescribing link workers, and not only placing them in primary care settings, but actually taking them into more of the community. So what would it look like to have social prescribers being based in job centres, being based in housing associations, being based in children's centres? That's definitely something that we're keen on developing in the new year. And Emma mentioned specialist social prescribing mental health. As I said, the community connector role is a really new role, and we're really hoping that we can continue some of that work that we've been doing in the last year, and really start to target. I think our idea is to really start to proactively engage with people before they reach a stage where they are sort of embedded in the community mental health team. So how can we start to identify mental health issues before they sort of reach secondary care, so at a much more of a community level? And a part of that is a lot of the work that our community connectors will be hopefully leading on. Have I missed anything else, Emma?
Great, thanks, Layla.
All right. I think that's okay. She hasn't responded, so I'm guessing that's all right.
I think she's nodding yes, all good.
Yeah, all good. All right, cool.
Thank you very much, both of you. I know that Elijah has a question, but I'm also very aware, so we have time for questions in a minute. But first of all, I'm aware of time, and our colleague Saul Marmot is here with us on the call today. He's one of the GP partners at Bromley by Bow, and I'm aware that he has to go at some point very soon. So, Saul, I'll hand over to you now.
Thank you very much. Hi, my name is Saul Marmot. I'm one of the GPs at Bromley by Bow Health, and I've been part of the centre for about 22 years now. One of the things that first attracted me to the centre was really that medicine was basically placed at the heart of the community. And one of the other things that attracted me in particular was the fact that it wasn't run by doctors. And I was working with people who were not necessarily medically trained, and certainly not working with NHS managers. And this kind of enabled us to do things a little bit differently. So in a way, we've been doing social prescribing for, you know, the last 22 years, but even well before I was part of it, you know, people were essentially sussing out the needs of the local community and finding a way and finding a person to be able to help and support that person with their social needs. And, you know, I remember the way that the social prescribing role sort of developed in the first place. You know, it started off as a gatekeeper role or a signposting role, moved on to a kind of a facilitator, and then has become a therapist, a care coordinator, all of these different roles within time. And as you've just heard from Emma and Layla, you know, this role is now very much part of kind of a community therapist, being part of making things better for the population, making things better for the individuals and the community, kind of enabling people to access healthcare, and and all of those things that we talked about from that first development has really come a long way. And continues to come a long way. So every time I have a meeting with Layla or with Emma, and every time I hear these guys speak, I'm surprised by even how much further things have developed. I suppose, you know, the kind of the key is that social prescribing and this model integrated with primary care is putting the community first, not the GP practice first. And it's putting the community first for the benefit of the community rather than to save money for the GP practice. There's a very good reason that I say that. You know, some of you might have come across doctors in the past. Some of you I know are actually doctors. I'm certainly one. And I know the way that things were at medical school, and certainly the sort of the people who I looked up to or had to look up to at the time. You know, doctors were the center of the universe. I know as a young thing, I was, you know, excited to make all the changes, to do things, to, you know, change the world myself. And it didn't even occur to me that there were people who weren't doctors who might be just as well placed as I am in order to make these big changes. You know, some doctors have done it really through arrogance over the years. You know, everything revolves around me, health revolves around me, everything to do with health revolves around me. And slowly but surely over time, fortunately, things have changed. We've got a different generation of doctors, different sort of training. And now we're starting to understand that actually most of health outcomes are actually nothing to do with us. And we're just part of a bigger team. So I remember when social prescribing first became a thing, even in Tower Hamlets, you know, you'd have doctors say things like, you know, I'm a doctor, I'm not a bleeding social worker. Obviously, they didn't really understand the role of a doctor or a social worker, I have to say, because, well, because actually that's not the role of either. So one of the advantages now, one of the places that we've reached is that I, as a GP, am part of a bigger team. I would actually challenge Emma and Layla on the lovely team map that they put up there, that it didn't have me or any of my colleagues on there. You know, are we not part of the same team? And this has actually made a massive difference to our patients, but also to my workload. So kind of alluding to what I said to you before, you know, a lot of doctors, a lot of GP practices have accepted social prescribing because it's a way of getting the problem of this patient off my desk. It's a way of saving my practice some money so that I'm not having to deal with this particular problem. And that's sort of in a way, I suppose, that with my cynical hat on, a lot of doctors accepted this because they realized that it might be taking some workload off them. And I think now that social prescribing has been around and available for a while for a lot of doctors, people are starting to realize that actually it's nothing to do with saving me time and money. It's a lot to do with, well, there's somebody who I work closely with who has skills and time that I don't have. And I need to respect that because essentially I've got skills and times that they don't have. And therefore, why don't we work together? And so basically, I suppose my take-home message is that as a doctor, as primary care, I'm very lucky to work at Bromley by Bow. I'm very lucky to be co-located with the team of social prescribers, but it is incredibly important that I don't see myself and them as separate, that actually we are all part of the same team. We all have skills, we all have time, we all have knowledge that each other don't have. And that will make a much, much bigger difference to our patients if we recognize that right from the start. One particular patient springs to mind from kind of recent times. It's a lady who was suffering very badly with her mental health. A lady who, unfortunately, for the first time in several years, was admitted to hospital for a mental health breakdown. And she was essentially being looked after by one of our general social prescribers, who was an absolutely amazing social prescriber, really, really dedicated, who was doing an awful lot of support. she was communicating with me backwards and forwards, saying, okay, Saul, this is what this lady says now. And I was communicating back to say, okay, I've agreed to see her tomorrow. And then communicating again to say, okay, this is now what she's saying and now what she needs. And it was very, very much a two-way relationship. When our general social prescriber realized that perhaps some of the mental health stuff was a little bit out of her depth, she got in contact with one of our newer members of the team who you heard about, called the community connectors, who essentially, for an easy description, are social prescribers who have a speciality in mental health. And so actually for a while, the three of us, the community connector, the social prescriber and me, were working together as a team around this patient in order to support her and make things smoother for her. Now, any of us who've worked with people who have mental health problems, you realize that this is enduring long term and that actually we didn't solve anything for this particular woman, but we continue to support her. And as a result of all of this, we are the people that she turns to when she's in crisis. She said this very, very clearly, that she trusts us, we listen to her, and therefore she will talk to us if she needs. And so that story sticks in my mind. And I could have given you 20 other examples in the last few months of how working closely with the social prescribing team or the community connecting team actually has made a massive difference, not only to the patient's life, but to the community surrounding them, and also to my life as a doctor. It's meant that I have an awful lot more tools in order to help, and I don't essentially just need to turn to medication. So sorry to repeat myself, take home message, all of you work as part of the team. If you're a doctor, realize that these other people have a lot of skills that you don't. If you're not a doctor, realize that actually some of us, actually a lot of us these days really want to be part of such teams and really want to practice holistically.
Thank you so much, Saul. Hopefully that was insightful for people here. I think that was quite interesting to hear your own experience. Just a quick question for you. I'm not really sure, but do you have any, so someone is asking in the chat, do you have any experience of using volunteer befrienders to assist with social prescribing and helping clients into services? And maybe Layla can help if...
I was going to say that's probably not one for me. That's probably one for the wider team. Yes, absolutely. We there are befrienders, and actually, oddly enough, that's one of the roles of the social prescribing team. Actually, are those support as well. So I'm going to be quiet now and hand over to somebody who knows a lot more than I do. Layla.
Thank you, Saul.
Yeah, just to answer the question, we don't have any volunteer befrienders. A lot of our social prescribers actually pick up that kind of work. So I mean, when we were working on site, we would support people to access services if they were finding that challenging. I know definitely in Emma's team, some of the social prescribers there have actually carried out home visits as well. I hope that's right, Emma. So I guess as well, it speaks to like what's expected of social prescribers as well, whether that kind of work is actually in their role, and whether actually it's a real benefit to develop some sort of befriending voluntary sort of service for social prescribing, because then that means that social prescribers can really concentrate on providing that one-to-one support to people as the complexity of their referrals only increases. Yeah, so to answer the question, our social prescribers kind of pick that up, but definitely think there's a benefit to having social prescribing volunteers.
Actually, so we are joined for the second part of this session by Liana Martin. I'm not sure if you're expecting me to talk to you now. And so Liana, do you have any, do you know about anyone who has that kind of befriending service within their
yeah, it's a really good point, and actually I was thinking actually there's some things I can definitely speak to on this subject. So my I'm the regional learning coordinator for social prescribing. It's an NHS for London. It's an NHS associate position. I used to do it based from the Bromley by Bow Centre as part of Dan's Insights team, and I'm currently working from Health London Partnership. occupying the same role. And so a big part of my job is getting to know lots of different social prescribing services across London. We hear about best practice across the UK. And also I run a network of social prescribing managers who are connecting with each other and sort of sharing their challenges and thinking about solutions together. And I do the same with link workers. This is one of the things that comes up time and again, and especially I think it was spoken to earlier about the link workers being the intervention themselves, especially when you're supporting people that are isolated and at a time when lots of services have been stepped down because of COVID. Actually coming back into normal ways of working. Link workers, the context is primary care is starting to really understand the value of social prescribing. They're getting more and more referrals. This is being able to use volunteers or a befriending service, organisations out in the community that can hold that individual for the longer term. So as the social prescriber can do some focused work in the shorter term, I think is one of the ways that will build resilience into the social prescribing service. And there are definitely examples of this. By developing those volunteering services or looking at the community development piece, building these organisations that can support an individual longer term, also can create a bit of a pipeline for social prescribers coming into the system. As we see this, I think the aspiration is for the link worker workforce to double in the next couple of years. And it's really important that the people that are taking on those roles reflect the communities that they're supporting, and actually volunteering programs happening out in the community could be a really good pipeline for social prescribing in the future. And there are definitely a couple of examples of this happening across London. What I would say is this is an area for development. It's something that a number of organisations are thinking about at the moment. Not a very specific example, but just to say that it is definitely something that's being thought about. Dan's nodding.
Thank you, Anna. Dan, just before, I was aware that there was a question from Elijah, and we said we would go into questions before going into a deeper conversation. So Elijah, I don't know if have we answered your question already, or?
Yeah, in various ways. Gosh, there's a lot there. Liana, I'd love to pick up a conversation with you. I think it's important that social prescribers are having conversations, even in boroughs that maybe don't concern them presently, because these things are growing in size. But towards perhaps Emma and Layla more so, it was just around like, I can see that this paradigm has shifted and you're evolving the delivery of social prescribing to sort of accommodate the needs of particular patients that maybe have more welfare concerns or more community concerns. I appreciate that. I wonder, in doing so, that has obviously required some evaluation. I'm a link worker within UCLH, so it's obviously primary care, outpatient focused. So maybe there's a different process there, but I appreciate that's something that you're looking to go into and elaborate with. So maybe I just wanted to ask the question around evaluation and good process around that to sort of ensure that pilots take off as they ought to, and communities and stuff are actually engaged beyond the 6-week funding pot or whatever it might be.
Thank you, Elijah. And Dan, I don't know whether this is a good time to talk about the outcomes measurement framework and the evaluation we're doing with that, or? Yeah,
okay. So I think the question of how, and Saul also alluded to this with his comment about, is it all about kind of reducing demand on primary care or whatever, which sometimes the NHS seems obsessed with. And I think the question of how one measures the impact and benefit of social prescribing is a very complex one, like all of these sort of social interventions, really. But there are a number of kind of accepted tools, or as they're called, validated tools. These are tools that have been used across a wide range of interventions to measure certain benefits of different types of interventions. And there are the one that the NHS is currently advocating for, and I think will select really and require nationally NHS funded social prescribing schemes to use, is the ONS4 wellbeing measure, which is 4 simple questions that get asked at the beginning of the relationship between a link worker and their client, and at some latter point to measure the change. There's a more complex one, which is called Warwick-Edinburgh, which comes in two versions, a short scale and a long scale. It's more complex, and it's one of the challenges of all of these things is, do they hinder the relationship between the link worker and the client themselves? The client feels that they're kind of being measured, and that sort of certainly doesn't set you into a particular relationship of equals. So you need a lot of care about how you introduce these things. There's something called the Wellbeing Star, which is certainly used in the Newcastle scheme, and it looks at I think it's 7 or 8 domains of somebody's life, like money, relationships, home circumstances, all those sorts of things, and asks them how they score themselves. The link workers certainly in Newcastle like that one because it's visual. It is a star, and you plot the points on the star. And it becomes a prompt for a discussion then with the client about, well, which of your areas of your life should we work on? So that they like that because it's not just a measurement tool, but it's also a planning tool. There's My Core, which we use at Bromley by Bow, which is My Concerns and Wellbeing, which is a very, very simple tool, which I think is, in a sense, the only one that genuinely measures to what extent the social prescribing achieves the change that the person is seeking to achieve. It simply asks the person, what are the 2 most bothersome or concerning things going on for you in your life at the moment? And to what extent, and on a scale of 1 to 6, are they concerning you? And then you do a latter score later, and it asks a well-being question as well. So it's 2 concerns and well-being. It's 1 simple well-being question. So it's 3 questions in total. And then you ask them at the end of the intervention, have those changed? And again, of course, the 2 concerns often are the discussion, therefore, with the link worker about how do we support you with those 2 concerns. One of the real challenges for social prescribing, and this is really what a number of people have talked about today, is that if 70 or 80% of health outcomes are socio-economically determined or determined in the community, how are you measuring the change in somebody's life in terms of the community? And so this, Marie Polly, who's one of the sort of leading academics who looks at social prescribing and how we evaluate it and measure it and so on, points out that, potentially half of the outcomes that social prescribing achieves are never recorded at all. Do people get their, once you've referred them on to third-party services such as employability programs, welfare advice, debt advice, housing advice, adult learning, joining community groups and reducing social isolation. The outcomes in terms of jobs or debts that people have had relieved of them, or new benefits they're entitled to but were never claiming, or whether they've learnt English as a result of being referred to an ESOL class, or whether their social isolation has been significantly reduced and they've got stronger networks and connections in their community. That's very, very hard to track those outcomes and hard to record those outcomes, certainly on a systematic basis. What you can do undoubtedly is look at case studies, really good case studies of what happens to people that are representative of the caseload that your scheme is managing, are a very, very good and very understandable way of people understanding what your social prescribing scheme is achieving. Saul, I can see you've got your hand up.
Yeah, thanks, Dan. You just reminded me of something actually really important to mention as well. When you were talking about the screening questions that different social prescribers and different link workers might use with their clients. So last year we did a small study in order to try and introduce some kind of screening social determinant of health questions in primary care. So this is before it moves on to link workers or social prescribing team. This kind of came from a bit of a study that we did with our mental health foundation trust locally, kind of looking at the relationship between all long-term conditions and mental health outcomes. So a little bit about similar to what Layla was saying earlier, we want to try and recognize that people are hitting a mental health crisis before they hit a crisis point. And actually, there's a tremendous link between people's long-term conditions and people's mental ill health. And so essentially, what we started off doing was trying to introduce these screening questions about the wider determinants of health into every single mental health review. But soon we realized that this wasn't enough. So what we have now done is managed to introduce five social determinant screening questions into every single long-term condition review. So in other words, if you have diabetes, you have asthma, you have COPD, you have dementia, you have any of, kidney disease, hypertension, every single person, every single year will have the opportunity to be asked these questions. And in order to try and find whether these questions were acceptable to people or not, we did a small scale study within the practice where we asked lots of our patients these questions as a study to say, how did it feel to be asked these questions? Were these questions acceptable? Were they too intrusive? And I think it was pretty much 100% of people said it was really nice to be asked those questions, to have an opportunity to talk about these things, whether they had issues or not. Fortunately, this has now been introduced into the long-term conditions template across the whole of Tower Hamlets and indeed across the whole of North East London. So for those practices who use EMIS in North East London, the social determinants of health questionnaires are available in the long-term condition templates. So that's also us doing our parts as clinicians, as health professionals, to kind of hit the same questions as you were mentioning, Dan, from another angle.
Great, thank you, Saul. And that's so interesting. It reminds me of an initiative that Mind developed some time back, which was to work with general practitioners to essentially ask a screening question around debt to all patients with long-term mental health issues, because there's a strong correlation between debt and mental health, both as cause and as effect. But one GP I recall in the booklet talked about the fact that she worked in a very deprived community. She suddenly realized that debt was so prevalent that she asks every single patient in every single consultation, how are you getting on with money? And because the incidence of money worries was so strong in that particular community. So there's a lot of really interesting stuff about how social prescribing and the kind of detection of issues gets built into general practice as a much more routine way of working with patients, which is really, really exciting. Maybe there's a thing that we might discuss then as a group, because I think we've got sort of two ends of a telescope, haven't we, really? There's the relationship between link workers and social prescribing in general practice, and then there's the relationship of link workers and social prescribing to the community. And they're not, there's not a gulf between those. General practice is part of the community as well. But it'd be interesting to hear maybe from yourselves, Layla and Emma, about how you see the development of social prescribing within general practice itself, like say the development of multidisciplinary teams and how social prescribing becomes kind of embedded, and Saul's already alluded to some of that, but how it becomes embedded within general practice. And then we'll talk a bit about the community, and maybe we can bring you in there, Liana.
Emma, I don't know if you want to, whether we want to talk about sort of the integrated work that's been going on across the charity and the primary care.
Yep, sure. So I think and I think what Saul alluded to, the sort of welcome challenge, which was, where is the rest of primary care on your team slide? And I think it's really about how you kind of integrate with who and when. And so I think because what we quickly realized through our mental health work as well is that you could end up having a multidisciplinary team for every single condition, because clearly it's just the way that you should work. So you could have a cardiovascular MDT, you could have a diabetes MDT, a dementia MDT, all of these different things. So I think what we've learned is really about building those connections and relationships and making sure that it's based on like a shared set of values, so that whoever needs to be around the table can equally be around the table for the good of that person that is kind of being supported. So the configuration of the team really doesn't matter, but just as long as that everybody around that table has that shared principle and that kind of shared set of values. So sometimes our blended or, you know, MDT teams look like a rapid response social prescriber and a general social prescriber. Sometimes it looks like a nurse and a social prescriber. Sometimes it looks like a husband and a wife, a GP and the social prescriber. So all of these different kind of configurations are possible because of that shared understanding and really good relationship building and engagement on all sides. So I think as much as you want to kind of engage the community and raise awareness of the types of work that social prescribing can do, and I say types because it is around the sort of community development work as much as it is around the one-to-one support, but at the same time you have to also engage your practice team. So even though we're sort of 10, 12 years in the making with sort of formal social prescribing, many practitioners are new to healthcare maybe, or have just never heard of it, or maybe have little interest in being involved in it. So it is about constant education for the practice side of, and sort of institute and education side. So Layla took a team of social prescribers to the school recently to do a presentation about, you know, what is social prescribing, so that when we work with them and they become part of the broader MDT, actually it's based on kind of, yeah, the shared understanding of how we work and what's of benefit to the person. So yeah, that's what I would sort of say for that as well.
And to you, Layla, so the part of our social prescribing team that you manage sits within the charity, not within the health partnership. So how do you get your team to be considered part of the general practice team as well?
Well, we started off by firstly integrating the social prescribers that Emma manages and the social prescribers that are part of the Bromley by Bow Centre. And I think that was really key for us, because obviously Emma's social prescribers are employed by primary care. They're very much embedded in primary care. They have really strong relationships with the clinicians. And even though our social prescribers on the charity end are based in those practices, it was really great having Emma's SPs on our team as well. And what I mean on our team is that everything that we deliver and support the team with, Emma's team are very much involved in that as well. So that includes sort of joint case management meetings, reflection sessions, and all of that. But more importantly, Emma's social prescribers, we've done a lot of joint appointments with clinicians, and that involves sort of some of the rapid response social prescribers and our generalist social prescribers and community connectors as well. What we've done recently actually is paired up our social prescribing link workers with a link worker that's primary care sort of employed, and that's really helped kind of improve relations between the charity side of things and primary care. We're really lucky in that traditionally the I guess the understanding has been there, but as Emma said, as new clinicians come on board, it's a constant kind of, you're constantly having to kind of build new relationships and re-engage and all of that. So it's an ongoing thing. Yeah, if that answers.
Do you feel that, yeah, no, that's fantastic, thank you. Do you feel that it's more difficult if you're not based in the same building, or do you think kind of having your link workers literally physically located in the same building as general practice is indispensable, or can you overcome that through other means?
I mean, we've had to overcome that because of the pandemic, because none of the social prescribers have been in practices at all. It's only recently we've started to kind of have those discussions about placing link workers back in GP practices. So we've actually, like most SP schemes and link workers, I can imagine, we've been having to develop these relationships and sustain these relationships via Teams and Zoom, and it's been really challenging. But I think that I think with us, we've been very conscious to continuously sort of update our referrers on what's going on with the client work and what social prescribers are doing, being involved, as Emma said, in those primary sort of those practice meetings, the clinical meetings as well. So all of this stuff is really, really important, being open to having, conversations with anyone from primary care and clinicians when they need to. So we've had to work, I think, extra hard because we're conscious that our visual face is not out there. And we're hoping we have, Emma's team and our team have a series of sort of outreach and engagement activities planned, hopefully for the new year. And I think the aim of that is to kind of increase the presence and raise the profile of social prescribing and population health. to the practices. So
Great,
yeah,
thanks.
I would love to hear what other people have done during the pandemic, because it's been a real chat. Leanna might be able to answer that because she's London-wide.
We actually did a session around building allies within your primary care network. I think it will be on the HLP website, but it was sometime last year. I think it was July or August last year. And the brilliant link workers in, I think it was Barking and Dagenham and Waltham Forest, they were putting their photographs on mugs with the referral criteria, social prescribing referral criteria, and how to make a referral on the back of the mug and mouse mats, just making sure that people are holding them in mind. I think it is really important that link workers, even where they're not based in surgery right now, are popping in and having some face-to-face, or maybe perhaps not right now, but at times where when it has been a bit quieter, link workers have been going in and having cups of tea with the people that are important, that are maybe can represent them on their behalf in meetings. We've also got the really fantastic North London is really leading on creating leaders within social prescribing. And I don't know if you want to speak to this, Layla, but I think building the skills within our link workers, seeing our link workers as the arms of transformation within primary care, and respecting that and giving them the skills and experience to be able to lead on some of that transformation work, I think is really is very inspiring. I'll let you talk a bit more about the project. I think you know more about it than I do.
Yeah, but it just brings me to, because didn't have much time to talk, but we obviously didn't talk about, as part of the Bromley by Bow social prescribing model isn't just about sort of how we support clients, but it's actually the support that we provide to link workers as well, because that's sort of really crucial. And Leanna, exactly your point is really seeing people's talents and specialisms and interests and working on those. And I think throughout the last year, people have really, our link workers anyway, have really stepped forward with what kind of areas they're interested in. And I guess as a service, it's up to us to kind of create those spaces and platforms for them to be able to kind of thrive in those areas. For example, we have social prescribing link workers that are really passionate about sort of health inequalities in particular, and how we can kind of create more platforms to talk about that. We've got link workers that are really focused on sort of leadership roles, link workers that are really interested in specific areas of concern, such as mental health, children and young people. And so what we've tried to do as a team is really create platforms and spaces for those link workers to be able to kind of use their talents and further develop the service for us. North East London has recently developed an emerging leaders piece of work, and what they're trying to do is encourage more social prescribing link workers who are interested in leadership roles to apply for this emerging leaders program. And it's really a pilot, but the idea is to train 10 or 12 link workers in leadership skills, specifically around social prescribing and management and leadership. And I think this is a really important step forward, because a lot of the time, link workers can often feel like there's a bit of a glass ceiling, and there's nowhere else to really progress to after sort of being a social prescribing link worker. And what we really want to do is retain the workforce by creating them these paths and these avenues for them to kind of develop.
Great. Leanna, can I bring you in with a question which I'm not quite sure exactly what it refers to, but I've got it here. I'm going to read it out. How do you find search doctors who might be able to support or secure funding for social prescribing to our community activities? And I'm not quite sure whether that refers to doctors who support funding for social prescribing link workers, or funding for the activities that are referred on to. But actually, maybe it's good to talk about both, which is because the number of link workers who are employed in any primary care network is in part based on the appetite of the GPs to employ more link workers. And of course, then there's the challenge of what are the services that they refer on to. And I know that you've just done a really interesting piece of work with a group of Year Here, the team from Year Here, about how we might support the funding and the commissioning of projects related to social prescribing. So it'd be really good to hear from you about both of those aspects, actually.
I was thinking earlier about the things that would be useful for me to talk about today, and I guess in my work, I'm trying to look at what are the collective challenges that might get in the way of social prescribing thriving. So how might we, where are there pockets of work that we can concentrate some efforts to come up with some solutions that will tackle some collective challenges? And definitely we held a town hall last year talking about some of the work that's happening at a pan-London level, and really wanted to hear from from link workers about what they deem to be the key challenges that we should be focusing on for the 12 months going forward. And the top thing that came out of that was activities in the voluntary sector. If the voluntary sector is not resourced, social prescribing is nothing if it doesn't have useful, meaningful activities to be referring people into. I think there's a number of different things that can be done there, and I think at the moment we're looking at a piece of work to joint commission between the health system, so NHS, so money coming from the ICS structures, alongside money from local authority, to fund activities that have been identified as gaps. There might be gaps in local services, or perhaps there's a particular service that's really useful to the individuals that social prescribers are working with, and they want to build the capacity of those services and make sure that they are well resourced and can increase the number of people they're working with, or perhaps extend it to people with specific complex needs. So what does a funding pot that sits alongside the social prescribing service look like? And it's looking like, again, North East London are the leaders in this. They've committed to raising the money and piloting this early next year. There are some examples of this happening in other bits of London. So there's a community chest attached to social prescribing in Wandsworth, and this is actually where you see social prescribing really leading the way in cross-sectoral relationships and partnerships that are needed to be able to make decisions. Emma talked a lot about population health priorities earlier. Who do you need in the room to be able to have a conversation about where in the Venn diagram, what is at the heart of the priorities for the population that you're serving? How can you use data to make sure that you're not just relying on that bias isn't getting involved in those making those priorities, and then thinking about what activities might be beneficial to those groups that might not exist already, or that might need better resourcing. We also know that link workers are creating so much intel about the needs of our local populations, and how might we use that data in a much better way. And this is something that, again, the team at Bromley by Bow have been really sort of on the pioneering and sort of on the coal face of, I guess, thinking about how we can use data in a more interesting way, and starting to code things so that can then go towards intelligent commissioning at a local authority level. So those are a couple of examples. I'm not sure if that is answering the question. Whomever asked the question, feel free to take yourself off mute. I think the one other thing to say is that quite a lot of money is coming through to support social prescribing, is coming through the ARRS pot as part of the DES contract to primary care. There is an underspend. And so there is a real opportunity to encourage our primary care networks to show them the value of social prescribing, and encourage them to invest in a lead link worker, somebody that might be able to coordinate the work with the other personalised care roles, the health and wellbeing coach and the care coordinator, a specialist if you're working with a particularly deprived community, perhaps thinking about some of the pathways work if you think that social prescribing can be really impactful with a cohort that perhaps have a combination of mental health issues and a long-term condition. It's getting primary care networks to think in a creative way about how these roles can be used to their, putting their superpower front and centre, which is building the bridge with local communities and actually working with people around the social determinants of health in order that they can better manage their health and well-being.
Great, fantastic, Leanna. And I heard recently that the underspend on the ARRS funding stream is £3 billion. So that money is sitting there unspent at the moment. Think how many link workers we could be employing, and or other roles. I mean, that brings me on to something that I think is really important that I wanted to mention, which is how does social prescribing help to inform the development of the primary care networks? And I think what's really, really interesting for us at Bromley by Bow is that our primary care network are now employing essentially a group of community development workers with the ARRS funding. So whilst it's very important to think about social prescribing and social prescribing link workers, you need to sort of, in a sense, if in terms of concentric circles, go one circle out beyond that, which is as well as people working on an individual basis, which is what link workers do by and large with clients. How might you also support people who don't then necessarily have to come into primary care to be referred to a link worker at all, but how might you be supporting people out there in the community? And of course, many voluntary sector organizations do that anyway. I mean, there are many voluntary sector organizations who have community development teams of one sort or another, and they probably go under many, many different names and guises, and potentially funded by many different sources of funding, from local authority funding to lottery funding to all sorts of other trusts and foundations and so on. But the linkage between social prescribing and those community development roles, and those roles that are as well around supporting individuals and communities out there in the community, is probably one of the really fundamental next steps for social prescribing, really. And of course, not in some places it already exists, but it's probably not general, and probably less so articulated with the new social prescribing link workers who've come in under the NHS funding of social prescribing. Because expecting link workers to, I mean, link workers are said to be able to work with 200 to 250 clients per year, but that's out of a patient list of, in a primary care network, of 50,000 patients. Even if you have 2 or 3 link workers, that still gives you a relatively small number of patients who can be worked with individually by link workers every year. And one needs something else that also supports communities in a more general way, both with individuals and with groups and with neighborhoods. And that probably requires another team of people who are involved with working within the community. As I say, what's interesting about our primary care network, where Bromley by Bow is based, is that our primary care network have decided to spend some of their ARRS funding on creating that team that sits within the primary care network, but they are not link workers and they're not clinicians. These are community development workers. And they've just employed a team of 3 of them who will work very closely with social prescribing, but work out there in the neighborhoods and so on. And I think that's probably a really interesting next step. I think another next step potentially is about training other organizations to do what I would call social prescribing light. So children's center workers, housing association workers, community center workers, faith organization workers, school parent liaison officers who are meeting parents in the playground in primary schools. All of those staff, those roles, could be trained to have an understanding of what social prescribing is, potentially use the same directory that the local link workers are using, so have access to that directory with that fantastic intelligence that the link workers have generated about what are the projects and activities and services that really work for our local neighborhood. And then obviously one wouldn't be expecting a school parent liaison officer or a children's center worker to have 6 one-hour sessions in a sort of private space with a person. But we know that these people are detecting social need in their clients. We know that they have conversations where people reveal social need, and therefore to arm them with some of the understanding of how to have that conversation and how to either refer or signpost to a common set of services that the link workers have already probably done a lot of the intelligence gathering about, would make a lot of sense, so that these people don't have to wait for their next appointment to the GP to mention the problem, but actually it could be anywhere that that person has contact with in that neighborhood. So you'd have 20, 30 organizations within that primary care network area who are working off a common directory of services, whose staff are commonly trained to a certain standard to have a certain type of holistic conversation with people. I think is probably another step in the development of social prescribing and primary care networks. And we're starting to use the phrase at Bromley by Bow, health creation networks. So how do we move beyond a primary care network that currently consists of 4 or 5, 6 GP practices to a network of 20 or 30 organizations within a neighborhood that include primary care, but include all of those sorts of organizations that I've just mentioned, along with the allotment group round the corner and the walking group who walk every Monday morning or whatever it happens to be. So it's not just institutions, but also kind of people within the neighborhood who are active or who are doing things, and create something called a health creation network with them, in which social prescribing has a very, very strong role to play, but it's also about community development as well. That's sort of some of the vision that Bromley by Bow is starting to develop for itself. It's very much work in progress. And we're always very, very keen to share ideas with others and to hear from others about the great ideas that others have got as well. So this is a common journey, that a big family, if you like, the social prescribing family. And this is very, very much exciting work in progress that we're all taking forwards and developing. And there are dozens and hundreds of good ideas from across the country and indeed across the world now around how social prescribing is being taken forwards. Berenice, I don't know if there are any last comments from any of the attendees. I'm not quite sure how we're off for time. We're coming into the last few minutes.
We've got time for maybe 1 or 2 questions. I know Lucy had her hand up a little bit ago. I'm not sure if we've answered your question already, Lucy, because you put your hand back down now. Okay, great to hear your question has been answered. And I know a little bit ago as well, Elijah had his hand up again. So I'm not sure if your question has been answered as well, or if you want to come up. Anyone else, feel free to.
Yeah, I actually do, if that's all right.
That's all right.
Thank you. It was sort of harking back to this idea of evaluation, and was it Saul that responded with these social determinant questions? I just wondered about the information sharing there, and if that then became a part of perhaps link worker flow, or maybe aided referral or flagging of patients for the awareness of link workers. I don't want to assume whether that is or isn't being done, but I'm interested to know.
So I think, Saul, what our primary care team have done is to incorporate these 5 questions about people's circumstances, their social determinants of health. And those are now recorded within the primary care data system. So that then becomes a flag to refer, obviously with patient consent, to social prescribing. So if somebody reveals that they've got whatever it happens to be, a housing issue or an unemployment issue or whatever, that then becomes a prompt for the clinician to explore that a little bit further with the client, and then make a referral in the same way they'd make any other referral to social prescribing. And obviously GPs and nurses and healthcare assistants and so on put down some information about what the issue is when they make that referral to the link workers. So some information travels with that referral, so that the link worker, when they pick that up, have got some idea of what the issue is that the clinician has detected and has caused that referral. Having said that, of course, we're all absolutely aware that what triggers the referral may not be the main issue for that person. And if you talk to any experienced link worker, they will tell you that they get a referral from a clinician about a particular problem, and when they're sitting down talking to that person, a whole lot of other issues tumble out as well, and quite often don't tumble out until the 2nd or 3rd meeting. So it's also about building up that sense of trust between the client and the link worker, in which the person starts to reveal other issues that are going on in their life. that may actually be the most important and critical issues to work on. So it is very much a process, yeah.
Excellent, thank you.
Is that helpful, Elijah?
Yeah, massively. I like to see that it's embedded in that, and is sort of, yeah, a part of conversation that's shared between clinician and link worker too. Thank you.
Great. Any further questions? If not, maybe last thoughts from Liana and Leila.
Do you want to go, Leanna? Do you want me to go? What do you want me to do? Last thoughts. Actually, Dan, I was just thinking a lot more about what you said about sort of the future vision and this idea of sort of social prescribing light that really excites me, because I don't think the answer is always to increase the number of social prescribing link workers we have in primary care networks and within the community. The answer is working closely with other key frontline workers that are doing very similar work, that are supporting the same people, but just embedding that whole idea of, you know, early detection of social issues and making sure that we're all working in a holistic way that sort of improves the health and well-being of the whole community. And I think in order to do that, we really do have to engage and come out of primary care a bit, and also make sure that we're engaging with those other key stakeholders, schools, as I said, job centres, youth prison services, and getting people to all work in the same way. So I'm just echoing what you're saying, Dan, and I think that's a really important vision for social prescribing in the future, I think.
Yeah, I completely agree. I think there's obviously we're seeing more and more places that the reason health service is investing in this is because they know that it's going to make people manage their health better, which is ultimately going to save the health service money. And the same is true in so many other settings. And that's the business case for doing this, but we should also be doing it because it is the right thing to do, and people need this extra support. I think there's the intention when this was rolled out across primary care networks was that there would be, the referrals coming from the community. It wouldn't be just clinicians that were referring. And I think thinking about how that can be facilitated is definitely the next challenge, both in terms of capacity, but also how tech and digital can be supporting this. I think there's going to be some really interesting conversations coming up around how tech and digital can genuinely support the development of social prescribing. And obviously the evaluation, looking at how well, how much this is the impact this is having, the money it's saving, what services we should be investing in a meaningful way, and obviously I think the community development piece. This is not link workers working within primary care is not just a means to support the work of primary care. It's thinking about how primary care can be part of, you always talk about this, Dan, a health creation network, and being the linchpin to build those relationships that are integral to making sure that a community is operating as a whole, and giving link workers the time to genuinely do this piece of work, thinking about what buildings can be better utilised, thinking about how volunteering can support the local population, thinking about what assets and resources are there that are being underutilised or should be better invested in, and elevating some of our link workers to lead on some of this work. I think definitely a priorities for next year.
Thank you very much, Jana. Thank you all three of you. We're running out of time now. That was a very good session, hopefully helpful for everyone here. Just to remind you, this was recorded, so we'll be sharing this in the next couple of days, along with a few links and some email addresses to stay in touch. You can definitely, one email that you're sure you'll get kind of forwarded to the right person or answered directly is insights@bbbc.org.uk. Sorry, that's in the chat as well. So yeah, feel free to send us an email and that will be forwarded to the right person. That's where it's easier to contact us. We also run social prescribing training and some bespoke workshops, knowledge share and exchange workshops for groups of people and teams. So please do keep in touch as well if you want to hear more about this. There's some information on our website, but we're also happy to chat to you about that. And yeah, we hope that was helpful, and thank you again to our speakers. and hopefully stay in touch, and also have a good break. Hopefully you'll get some time off during the holiday. Thank you, everyone.
Great. Thank you, everybody, as well. Yep.